Today, cannabis-associated psychosis, and whether it represents a distinct subtype of first-episode psychosis. A patient walks into your clinic first-episode psychosis, male, in his early 20s. His cannabis use history is extensive. You've seen this presentation before. But here's the question that matters. Is this just psychosis with cannabis as a coincidental bystander, or is the cannabis actively shaping this illness? A Yale-led team put this question to the test. They studied 119 males hospitalized for new-onset psychosis, 66 with confirmed cannabis exposure before their psychosis began, and 53 with no cannabis exposure. Both groups received standardized inpatient treatment and were assessed at admission and again at 4 weeks. They measured cognition using the Cogstate battery and the Hopkins Verbal Learning Test, EEG brain activity, and clinical symptoms across the PANSS scale, plus depression and mania ratings. The first major finding challenges a common assumption. At admission, both groups had identical cognitive performance, but after 4 weeks of treatment, the cannabis-exposed group showed significant cognitive improvement, while the non-cannabis group did not. This is counterintuitive. Cannabis is often blamed for worsening cognition in psychosis, but here, cannabis exposure was associated with better cognitive recovery, not worse. The brain scans tell a different story. The cannabis-exposed group had a significantly higher power spectral density exponent on their EEG at admission, and this exponent is a proxy for cortical excitatory and inhibitory balance, your brain's ratio of firing to silencing. A higher excitatory to inhibitory ratio in the cannabis group suggests a distinct neurobiological fingerprint. This isn't just psychosis with weed. The brain's signatures are different at baseline. The clinical presentation also diverged. At admission, the cannabis-exposed group had lower overall psychosis symptoms on the PANSS, and specifically fewer negative symptoms. But they had significantly higher depressive symptoms on the Calgary Depression Scale and higher manic symptoms on the Young Mania Rating Scale. So the phenotype is different, less withdrawal and flatness, more mood elevation and depression. It's not a textbook schizophrenia presentation. It's a mood-enriched psychosis at the front end. Perhaps the most urgent finding, 16 cannabis-exposed patients were tracked after discharge. 10 of them were hospitalized for psychosis exacerbation, and all 10 had resumed cannabis use. Among those who stayed abstinent, relapse was rare. Cannabis is not a correlate of psychosis. In this population, cannabis resumption is an active relapse trigger. The implication is direct. Abstinence counseling is not optional, it's a core part of psychosis recovery. So what does this mean for your practice? Screen for cannabis use in every first-episode psychosis presentation. It's now standard of care. When cannabis exposure is confirmed, recognize you're likely dealing with a phenotypically distinct subtype, better cognitive prognosis, mood-enriched presentation, but a critical dependence on abstinence for recovery. Integrate substance, use treatment into your psychosis care plan, and counsel families. Cannabis is not neutral in this illness. In cannabis-associated psychosis, continued use actively drives recurrence. For questions or episode ideas, drop them below and subscribe for more psychopharmacology breakdowns. Educational purposes only, not a substitute for clinical judgment.